Welcome to Michigan and AARP Real Possibilities. If you're in Michigan, then you know a little bit about the impact that Michigan can have on seasonal affectiveness disorder and what it does to your mental wellness. Stay tuned as we talk with Dr. June. I am so happy to have you back with us again. It's been way too long since you visited Real Possibilities.
Yes.
It had, but you've been very, very, very busy doing all sorts of wonderful things and taking care of the whole wide world and educating and informing people. And I still use your quotes, Dr. June. Anytime someone goes to the doctor, you told us to ask two questions. One, what is this medication going to do? And number two, what's the plan for getting me off of it? I love that. But today we're going to talk about something different that's not as tangible. We're going to talk about the seasonal effect that Michigan can have. Post-COVID, the dark days, the gray days. That's also something people should be very aware of as well, correct?
Oh, very much so, especially now.
And so talk with us a little bit about what the seasons can do to someone who's at home, someone who might be fighting social isolation, and some of the challenges they have just being alone.
Well, there's a lot to unpack just with that.
Just go for it.
But without even addressing like the isolation that comes with illness and the pandemic, there is something called acronym SAD, which is Seasonal Affective Disorder, which is alive and well here in Michigan. And that involves when there's more cloudy days or the weather is such that you spend a lot more time inside and the light levels are lower. This disorder was kind of fleshed out fairly recently in the history of medicine. And they found out that anyone who is particularly isolated or they're around very dim lights and they're not getting a lot of sunlight, not getting outside, they start to develop physical depression from it. Now add to that people that might be inside and isolated due to worries about the pandemic or depending on the time of year that there's nowhere to go or they don't have interest in hobbies going outside, they're not exercising as much, that can really damage their mental health and well-being. And so I like to talk to my patients about that because often they don't bring it up with their physicians. So I ask them, are you getting exercise? Are you getting outside? What kind of lighting do you use? Do you know what a happy lamp is? Mm-hmm. And these sort of things.
And so a happy lamp, I've been doing a little bit of reading about that, and there was something mentioned about that in AARP magazine as well, and the impact that it can have. There really is something called a happy lamp. Right. Talk about that.
So they come in a lot of different names. It could be a light panel, a wellness panel, a happy lamp, happy light. There's a lot of different things. You can go online and type that in, and it'll give you a variety. But basically, the idea is it should be somewhat of a full spectrum light. It should be in your off your vision, so you're not staring directly into this. So it's going to be offset, and it's going to illuminate your room and objects around you and yourself. And you're supposed to do that 30 minutes a day, no matter what the weather is outside, while you are inside. By doing that, it's been shown to reduce depression in a variety of people, no matter what their age, and has been very effective. A number of studies have shown that actually something simple as that has been very good for your mental wellness. Your energy levels, your activity levels, and it's just overall for a small investment is a really great idea for most of my patients, at least in Michigan, is to have one of those that they pull out when the skies are dark or they're just not getting outside very much.
It's amazing, isn't it, how just a short walk can make such a huge, huge difference in someone's life, that movement. When people are too stationary, what are some of the things that can go wrong?
Well, I hate to say something so kitschy, but if you don't use it, you lose it. And the same thing is with our bodies. Often in the summertime when it's nice out or it's sunny and it's nice weather, it's easy to get outside, go for a walk, go around town, go visit the neighbor. But in the wintertime or when it's raining or Michigan weather, sometimes it's just hard to get out. And if you're not getting out, getting that walk, you're not taking your pets for a walk, you're not just going outside and visiting neighbors, it starts to wear on you. And actually, they've shown that people who exercise less are in more pain. And so even simple things like a mile walk or getting on a treadmill would make all the difference. It's difficult for a lot of my patients to just kind of tell them, go buy a treadmill and put it in your house, because a lot of them are, how do I put it in my house? Right. And how do I get this? And, oh, I had a treadmill. I'm hanging my clothes on it. I don't use it for anything. Or I did that great for January onward. but I'm not using it anymore, and it's like it just falls in the wayside. And it really comes down to just putting yourself first. And when you put yourself first, you're going to exercise, you're going to find ways to get out, either to a gym or a treadmill or outside, or and basically just take care of your body, because if you don't, it won't take care of you.
That's very well said, extremely well said. And when people who are not prone to be able to go outside on their own, they have to have some assistance, whether it's a visiting nurse, someone coming in, what can they do at home besides the light? They can't use a treadmill. Is it stretching, or is there anything else that they can do that?
There is a lot of great books out there, and I'm not going to plug anyone specifically, so I'll give some general ideas. But basically, these are exercises you can do in a chair, in a bed, on your own, that you can do without any equipment. And so sometimes they're called like body weight exercises, but you just type that in as like body weight exercises, or you put in like exercises I can do from home, like into a search engine, and it'll pop up a lot of great material. A lot of times we can talk to our primary cares, and if you're one of my patients, like sometimes we hand out a whole manual that we hand out to our patients that tells them hundreds of exercises they can do, but a lot of primary cares will help guide you in a direction they think is tailored for you. So I can't say specifically to everyone listening what the right thing is, but exercise is the right thing, what to do. Talk to your primary care or your physical therapist, or if you have an expert a physiatrist of some sort that can help you with that, or a personal trainer, or if none of that's available to you, a family member that really knows their stuff, anything to get you active and moving. But it's a good place to start with our primary care.
And talk about the impact medication can have on someone. So many times we are, in my opinion, not yours, overprescribed, in medication. They can have a negative impact on your mental well-being as well, cause a little bit of depression. What should people do in terms of whether or not they should be taking or not taking all this medication, and the impact that medication can have on them?
Well, it's one of those things. Here's the deal. If there's patients out there that are overprescribed, you're correct. And if you tell me there's patients out there that are underprescribed, you are also correct. That's the whole having a great relationship with your primary care or your specialist, and you go in and you ask, why am I on this med? And have them write it down, or have the physician write it down. And do I need to be on it, or how do I get off of this med? And some of the meds you can't, but some they can say, well, is it working? Well, no, then don't take it. So you have to have your primary care guide you with that and be the leader with that to give you some good advice. Now, as seasons change in Michigan, oftentimes, and we all, if it's not ourselves, we all know someone that says, I feel there's a storm coming in, and their knee starts going bad on them, or all their joints start hurting. This is especially true with people with bad osteoarthritis or autoimmune inflammatory diseases. And that could be a sign that there's barometric changes going on. And it's not really arguable, does that really happen? Of course it does. Sometimes is you just exercise, you stretch, you work through it. Sometimes you need to talk to your physician, your specialist about that, and see, do I need something just to get through those flares? And that's appropriate. But as far as kind of what you're saying about medications, am I on the right medication? Should I be taking this? Or am I on the right one for me? Do I need something else because my life is miserable? And physicians aren't God. So they try other meds on you, and they try to tailor it the right thing for you. And sometimes it's great and you feel a lot better and you feel like your life is going the right direction. Sometimes you get frustrated, and that kind of goes into what we were talking about earlier about depression. I'm on all these meds, I feel miserable, and that can lead people down that state of feeling hopeless. Don't do that alone. Talk to your primary care. Talk to your specialist. Talk to your friends, family, loved ones, and neighbors. Don't go onto Google, because it's just going to terrify you and give you bad advice anyway. But it's one of those things that you need to kind of take that back in your hand, and knowing that tomorrow might be a better day and I'm going to work towards it, and someday it will. And so there's no reason to lose hope, because there's always other things we can try. There's alternative therapies. There's non-medication therapies that are out there that can really help people turn around, and physicians are there to help you with that.
Right. And I like what you said about taking control of your own life, that you are your biggest advocate, or you should be.
Yeah.
So you're looking out for everyone else, grandchildren, children, next door neighbor. Look out for yourself and do what's good for you and what's best for you. And make sure you have a plan, right? A plan for every day, how to exercise and how to move and what you're going to be doing. Someone told me that once they retired, the worst part was getting up and not having a purpose.
Right.
Not having something to do. But if you're taking care of yourself, and you have a plan for yourself, that's at least one thing you can do. And we encourage people also to call someone to reach out, someone that they know, don't know, just to avoid that social isolation by knowing that someone cares for you. What else can people do to take control of their own destiny?
Well, when I first started as a fellow, when I was getting into rheumatology, I came up with a probably not too appropriate saying, is that the leading cause of death is retirement. I had a lot of patients, and I'll generalize it so it's not, no one specifically thinks I'm talking about them. But I have groups of patients that come to me and they say, well, I finally retired. I'm like, all right, what do you got planned? They're like, fishing. Well, good. What else? What hobbies are you drinking beer? I'm like, that's probably not going to, it's not going to work for you. You need a plan, you need a purpose. And fishing and beer is great, but that's not an everyday thing. You're going to get bored of it. It's not good for you. So then I have other ones that said, man, my life began when I retired. That's when I started getting really busy. And they say, Dr. June, I'm busier than I've ever been before. And these patients tend to do well, they're happier, they're in less pain, and they're constantly active, whether it's with their hobbies, their new groups, with their grandchildren, their great-grandchildren. I find them that my patients that join groups they wouldn't have normally. I have one told me, it's like, I didn't even like bowling. Now I'm in a league and I love it. Or a golf league, or a book club, or a church group, or whatever it is, and they get more and more involved. And there's something to be said about that, because those are my patients that have the best mental health right now, and physically they feel better because of it. So I highly recommend that you fill your life with a purpose and you choose to be busy, and by doing so, happiness comes with that. And it won't feel like, oh, I got to wake up and get this stuff done. You're happy to wake up, and then you got a purposeful filled day.
Right.
And that's the big difference between my patients that are kind of wandering with no purpose and those that have an agenda.
Right, and watching television or Happy Days or whatever shouldn't be part of that.
Except for watching us on TV. That's
exactly,
okay.
Absolutely. That's how you should be working
Yes.
out and talking right now and exercising right now.
Yeah.
You know, there's another part of mental health, mental wellness is dementia, Alzheimer's, and how people may not be able to do, they can still function on their own, but they're not able to do all those types of activities that they once did before. And they're home. Alone or else with someone else. Any advice for them, what they can do?
Well, dementia comes in it's a whole rainbow of forms. Generally speaking, if we live long enough, all of us will have some form of dementia, or at least a little bit, and some might claim earlier than others. But it can come in the most severe forms that eventually lead to an early death, and other ones which just come with aging, where we're just not as quick as we used to be. Like, you know, the brain, the ticker's just not working like it used to be. So that's complicated. The science of the study of dementia is burgeoning, meaning that we're just getting into it now, finding out, did the medications we had previously work? Does doing crossword puzzles, does that help? Does all of these things? And we're getting past the basics, knowing that exercise, using your brain mentally, and reading, staying active, and eating correctly, all of those are very, very much help protect against dementia. Vitamins, minerals, vitamin D, all of that's a part of it. Fish oils, to some degree, can help. But genetics plays a part of that, too. If Alzheimer's runs in your family, unfortunately, no matter if you do everything right, you might end up getting a part of that no matter what we do. And that's scary, but the science is really following up on that. We're starting to move in the right direction, understanding it. Now, one thing that people don't know, and I'd like to put a thought in people's head, is when we get older, we often lose our hearing. And it seems like physicians and audiologists, and to a point neurologists, aren't bringing it up enough with patients, is that once your hearing goes, your chances of dementia skyrocket. Nobody likes wearing hearing aids. I get it. They're annoying. They buzz. You know, the kids give you funny looks and stuff. And I remember my own grandmother, when the kids were over for holidays, she turned those suckers off and she was happy. But the problem, though, is with the loss of hearing, it actually accelerates dementia and mortality increases. So very important to our senses, the health of our senses, that we stay on it. We wear our hearing aids. We go to an audiologist. We find a way to get those very expensive hearing aids that are never covered by insurance. But we really do need to focus on that, because that helps protect our brain. By keeping it active, our senses of taste, smell, vision, and hearing all help protect our brain too. So it often gets overlooked, but that's very important, is to make sure our hearing is in good shape.
That's excellent advice. That's one of the reasons why we being ERPs, been such strong advocates of getting hearing aids covered by insurance or part of Medicare as well. So, excellent advice. As a rheumatologist, what are some of the top, I don't want to say ailments, but top issues that you see when people come in? What are the top two or three things that you find people suffer from?
It depends on the age group.
Oh,
So
okay.
lately,
Well, let's talk about my age group.
oh, they're perfect in every way.
Oh, thank you. All right.
No, for stereotypical patient that I'd see in the office, if we get old enough, just like I said earlier, if you live long enough, you're going to have at least some osteoarthritis, and some people a lot. And I would say that we all know a person in our family or ourselves that's got chronic low back pain, and that can be disabling. That is one of the things that gets people into depression because they can't get up and do what they want to do. They can't run around, they can't bend down, and they're in pain all the time, and they have to think about pain all the time. So it's extremely important to make sure that back pain's taken care of. Oftentimes people can work around a hip pain or knee pain, but it's that low back pain that can be real crippling. Other than that, yes, is osteoarthritis of the hands, the knees. These little joints, we call them the CMC joints in the hands, right in the base of the thumb. That's super typical of my older patients as they get older, using their hands physically. It's because the entire weight of the world is on that joint. Every time you shake a hand, you can actually feel that right there in that CMC joint, and it wears out. And that can make gripping things difficult. And oftentimes we start having to use like special devices for popping jars. And I have another theory is that once we reach a certain age, we are attracted to pickle jars and we want to open them because everyone comes in and says, I have trouble opening a pickle jar. I'm like, you eat pickles too? Okay. But that's the idea, is that those joints start giving us trouble. And just to know if you have a little bit, if you ever did a push lawnmower that vibrates and you held it for any length of time, when you're done, it will hurt. Ache and burn in that area, and that tells you have some pretty good osteoarthritis there. And managing that, it can be done with a rheumatologist, primary care, orthopedic surgeon, specifically hand surgeons. There's a lot of things that can be done for it.
How do you know when you should see rheumatologists?
Well, generally that's going to be up to your primary care, generally speaking. In Lansing, we're fairly available, but a lot of part of Michigan doesn't have access to rheumatology, so it has to be done through internal medicine, primary care, or even sometimes, unfortunately, orthopedic surgery. They're great at surgery, but like chronic conditions, they don't want them. So for a referral to come to us, generally speaking, your primary care will handle that. Now, there are instances in which patients, whether they didn't advocate enough for themselves, where family members might want to ask on behalf of their elderly parents or sister brothers or other family members to get them into a rheumatologist when they think that we're just not getting where we need to be for our autoimmune problems or our arthritic problems. Maybe we need another opinion or take it to a specialist. That's when they come see a rheumatologist. And so we do manage, and we're getting much better at it. Chronic pain, osteoarthritis pain. A lot of rheumatologists are using newer modalities that are available to us. And so that includes getting them into physical therapy, injections, certain types of oral medications, or non-medications, such as something we call OMM, which is osteopathic manipulation medicine. And that's a manipulation type of thing where we're actually adjusting muscles, sometimes joints, in a non-aggressive manner. And that can help a lot with people with their various types of pain without having to take pills, which that's been wonderful in our office. And we live in near MSU. That's have an excellent program over there as well.
You know, you mentioned before that some of these things can actually be reversed, and that so you don't have to learn to live with it or even minimize the pain. Sometimes it can actually be reversed. I mean, like maybe lower back pain, maybe not. Maybe the certain osteoporosis, maybe not. But there are certain things that can actually change.
Yes. I never promise anybody, when it comes to low back pain, that's its own animal. I never promise anyone that it's going to be 100%. All I can say is that it'll be better than where you started once we start therapy. Unfortunately, some people that's only 5% better, and that's worst case scenario. And people are disappointed in that, and as they should be. And we try all sorts of things. It doesn't just seem to help. And we'll go down the list of our many modalities of what we can try. Other people, we've been able to, with a handful of injections, physical therapy, tell me they feel like a whole nother person, and they say, Dr. John, I don't need to see you. I'll come back in 2 years if I need you for anything. So those are the extreme examples. Most people can expect to fall somewhere in the middle of that, better than where they started. but some of that can be reversed, and sometimes we lock out. Now, without getting into all the details, sometimes people do need a knee replacement. Sometimes people do need a discectomy, like a disc in their back taken care of, or a pinched nerve to be widened up again so that they have chronic pain shooting down their leg. It fixes that. That can be done through surgery, and oftentimes people feel pretty good. What I don't want people to get into, and often what they think about a lot of surgeries, is they don't want to get one surgery leading to another, and then they have metal all over their body and they don't feel any better. And most physicians, including myself, none of us want that. We're not going to push people into that direction. So we do our best to make sure that the right modality for the right patient, to try to get as close to 100% as we can, but at least as good as so they can go about their business, live their life, and have, like I said, happiness in their day-to-day living, and so they can live purposefully.
And that's a word that we use a lot, but it's so significant, living purposefully.
Yes.
In order to do that, you've got to make certain you're taking care of yourself. We've got about a minute and a half left, so talk, if you would, just a little bit about the impact that medications, if you're taking, is there any such thing as too many medications? I know people are taking 20, 13, 14 every day.
We talked about that a little bit before, but I'll get into that. So the problem is sometimes patients do need that many because they have a lot of chronic and life-threatening conditions. There's a specialist out there, and they're harder to get into, in my opinion, than even a rheumatologist, and they're called geriatricians. Geriatricians are physicians that are specifically aimed at the aging population, and oftentimes their main job is to take people off medications to help them live better without we call it polypharmacy. I adore geriatricians. They're very difficult to find though, so we all are working together to have more of them available in Lansing and greater mid-Michigan area actually. And if you can, it would be good to get an opinion from a geriatrician as we get a little bit older so they can go down that list of meds and either swap them or remove them, and they are excellent at doing that. As a rheumatologist, I do that all the time. We can go down the list. Generally, I'll give them a recommendation because one thing my primary cares don't like is when I screw with all their meds. Unless it's life-threatening, I'm not going to do that. But I will give them advice and write it down, or even call their primary care and see that we're all on the same page, because that's where it needs to be. The patient and all of your specialists working together, and then we can approach that big, huge list and say, what don't we need off this list, and take them off one at a time. And so generally speaking, with most of my appointments, we look down that list and say, did it work for you? Didn't? Try off of it for 2 weeks. Give me a call. If you don't feel any better or different, it's gone, and we'll move on to something else. And patients really appreciate keeping that list low.
Absolutely. Geriatricians is something that we've talked about a lot in our medical circles, and they are extremely rare. People don't seem to want to take care or look out for older adults, so we have to look out for ourselves. So that's not a practice that they're readily going to. So we need to make certain we have information like this, right, so that we can take care of ourselves and look out for ourselves. And people are living longer than ever before. 85 yes. years old is the fastest growing age right now, and people aren't planning and taking care of their bodies. They might be financially planning, but not necessarily physically planning, their own physical health and well-being. But it's never too late to start, right?
Never.
It's never too late to start. So thank you so much for everything that you do, for being here. 2 tips to leave folks with as we leave the program.
2 tips is, 1, no matter what, get outside or get exercise inside and make it a part of your daily routine. The benefits to that are dramatic. The hardest part is getting started. It takes 2 weeks to make 2 weeks to make a habit. That's it. And after 2 weeks of following the same pattern, it won't be difficult anymore. And the second thing is, make a relationship with your primary care and talk to them about all of these main things. And it's okay to be direct with them. Doc, do I need to be on all these meds? Let's talk about it. And that just says, make a great relationship with your primary care and go to your primary care. That's the thing.
Excellent advice. Thank you so much. We appreciate you. And thank you for watching Real Possibilities. Chris, thank you for being here with us. People, young people, middle-aged people, older adults, at what age should people start looking at a financial advisor?
Well, financial planning is important for all ages as you're starting to accumulate wealth, but really working with another professional, a financial planner, a certified financial planner, really as you're moving from the accumulation stage of life where you're accumulating your wealth, you're saving, really what we focus more on is on the preservation and distribution side. So we're really working more with clients who are near retirement age as they're looking at moving money out of their 401ks over into IRAs and trying to figure out how best to create that income stream in retirement. That's really what our focus is on. That said, financial planning is important, and there's other financial advisors that help with other areas, including savings or college planning.
And so is there any such thing as being too young to talk to a financial advisor?
Well, I wouldn't say too young, but you have to have a certain level of income or assets because we aren't nonprofits. We have to get paid somehow. So really it's more of just once you start to have something that you value, figuring out ways to best plan for that moving forward.
And at some point, we'd like to talk about why you're needing a financial advisor. So maybe our next segment, we can do that.
Yeah, that sounds great. And yeah, there's a lot of questions that we can answer for our clients. Like, for example, today, I was talking to some clients and we're talking about whether they should sell their home down in North Carolina, should they rent it out, and how that'll fit into their retirement.
Sounds good. And those are all things that you may or may not be able to decide on your own, but it certainly helps to have a financial advisor there to kind of guide you through what the tax implications are of some of those decisions, correct?
Right, yeah, it's always good to bounce ideas off of an expert and really work in partnership.
Thanks for being that expert for us today.
All right, thank you.
Thank you. Talking about transportation with CATA. Thank you for being here, Lolo. Appreciate you being here today. A lot of times people have mobility issues and they can't access CATA, a regular CATA vehicle the way that other folks can. What options do they have?
So all of our buses are equipped with wheelchair lifts and access for those who are, mobility challenged and need some assistance in terms of boarding and alighting from a vehicle.
And if they didn't want to ride a regular CATA bus, there are other options as well, but they'd have to schedule those?
That's correct. They can call our paratransit dispatcher and get those trips scheduled, and that service is, again, curb to curb, arrives right at your doorstep, and you board the bus and it takes you right where you need to go.
And so what's the difference in cost and convenience between the regular CATA bus and using the mobility accessible wheelchair ramp or the curb to curb? What's the difference?
Fixed route buses are the most affordable. It's either $1.25 per trip in one direction or 60 cents if you qualify, if you're eligible for it. The other option is Spectran, and that is $2.50 per one-way trip.
Well, that's very reasonable, particularly with the cost of gas. So when you say 60 cents, what's the difference between if I qualify for the 60 cents ride versus the $1.25 ride?
So in terms of our conversation today, 60 cents would be applicable to senior riders, and they would just need to get a CATA card, CATA Club card, and that would be what they show the operator when they board the bus.
Excellent.
And they get that 60-cent fare.
We need to make certain that people know about that. And so the senior is starting at what age? 45?
65.
50? Oh, okay. I was just
Yeah.
at 65 years old. All right. So that's news that you can use from CATA. Thank you for being here today. Thank you for watching AARP Real Possibilities. Lots of good information today. Share it with someone. Hopefully it's news that you can use.